Good afternoon, everybody, and welcome to this afternoon's talk, Enhancing Distance Vision for the Visually Impaired. Our guest is Dr. Henry Green, and we met Dr. Green. Well, Hazel, I think, knew him from before, but I met him at the conference in Ireland last year. And that was really an incredible opportunity for us to meet people and chat a little bit and ask, whether we could host them as a guest on our webinars. Henry, I'm not going to introduce you, but if you will introduce yourself.
Well, it's a pleasure to be with you, and thank you very much for the invitation. And I hope that what we're going to review over the next hour is of interest and helps you. As you know, I am an optometrist, and I've practiced low vision care for over 40 years, both in a private practice setting, in an agency setting, in an academic center, and I ran the low vision rehab program at the University of North Carolina in their Department of Ophthalmology for many, many years. And I also became involved in developing bioptic telescopes, and I'm the co-founder and currently president of Ocutech, and we design bioptic telescopes that address some of the concerns that we have as prescribers in making them easy to prescribe, easy for the patient to use, and as hassle-free as possible. And I will talk a little bit about our products and how they're used, but mostly what I would like to share with you today is what I've learned from 40 years in clinical practice about managing patients that have distant visual impairment, and some practical things that I hope that you'll be able to put into use in your practice even tomorrow. So let's get started. By way of full disclosure, I am the president of Ocutech, and I do derive a salary and hopefully a little bit of profit from my involvement in the company. So why should we be even thinking about improving distance vision? Our patients come into us complaining that they can't read well, expecting that they're going to need a stronger pair of reading glasses. And if it turns out, or they find out that it's going to become much more complicated than that. And they find out for many of them for the first time that they have something called a macula, and that is not working very well. And certainly there are plenty of ways to access the printed word rather than reading ourselves. And the reality, of course, is when someone has a significant visual impairment from central vision loss, they're not likely going to be reading for pleasure any longer. They'll read for need. They'll need to read their bills to pay their bills and write checks, read recipes, read price lists, things of that nature. But they're not going to sit down very likely to read a novel. And so there are plenty of non-visual ways to access the printed word. We can get books on tape. People can read to us. We can listen to the TV and radio. So accessing printed material is not that terribly much of a challenge. But no one can see the world for us. We need distance vision to read body language, make eye contact, and loss of distance vision seems to be correlated to impact on quality of life, and to a much greater extent than does loss of reading vision. It can lead to feelings of isolation and to lead to depression. And there are no non-visual alternatives to seeing the world around us. I'm a grandparent and I want to see my grandchildren, and no one can see my grandchildren for me. In addition, distance vision is a vector to opportunity. It supports independent travel. It supports academic and career opportunities. It's not to say that people that are severely visually impaired can't succeed in all of these areas, but it certainly can make it more challenging for them. Barry Rovna, an ophthalmologist, published a paper in the Medical Association Ophthalmology Journal, and he says, vision is the primary way that people engage with their world. We all know that. And when you compromise it with AMD, and I would suggest any central vision loss disorder, it disengages people from their world. It's not surprising that people get depressed. And up to 30% can develop clinical depression. And then he says low vision rehab and behavioral therapy can alleviate that depression. And he says people struggling with vision loss, and I think struggling isn't quite the right word that we ought to be using, but what he said was struggling with vision loss should not only look for an eye doctor, but specifically a low vision optometrist, all of us. And I will propose to you that there is no specialty in eye care or in healthcare that's better trained and better suited to providing low vision care than optometrists. We have pathology, we have binocularity, we have perception, we have optics, we have everything we need to help these people. And while there are other specialties that are involved in helping support the rehab and training of what we prescribe, OTs, PTs, vision rehab teachers, and orientation mobility people, it really should be, in my opinion, the low vision optometrist who is at the center of this, the primary director of all of these services. No one else has as holistic a perspective on all of the needs of these patients. It used to be taught in optometry schools, especially in the US, that it takes formulas and lots of time and it's not remunerative. And I will tell you that you really need very few, if any, formulas to provide low vision care, number one. Number two, with the new technology that's available, helping these individuals is easier than it's ever been. And it can indeed be remunerative. In 2018, another article in JAMA Ophthalmology called the Salisbury Eye Evaluation Study, Treating the Eyes to Help the Brain. And they looked at the association between vision and cognitive function. And what they found was that worsening vision appears to have a greater detrimental effect on declining cognition and vice versa. In other words, it's the vision that causes the declines in mentation and cognitive function. And it's because if you can't see things, you don't do things. And if you don't do things, you are less engaged, and it leads to those declines in cognitive function. And they say our findings reinforce the importance of primary prevention. Of course, if we can help them not lose vision in the first place, that's even better, but also the treatment of correctable visual impairment. And I will suggest to all of us that individuals with low vision, 660, 690, have correctable visual impairments with low vision care. But don't forget our 612 and 615 and 620 patients, they are visually impaired as well. So when we're talking about reading vision, enhancing visibility is pretty straightforward and patients can understand it. If they want to see, if the smallest they can see is the 4M text at the top of this chart, and the goal is to have them read 0.8M text down at the bottom, we have to make the 0.8M text that big. We can do that with optical magnifiers, electronic magnifiers. We can make the print really big. But if they can't read the top print, making the bottom print that big won't be effective. So making print larger, everyone can get their head around, so to speak, in terms of understanding what we're doing. But if a patient says to you, well, I'm jumping ahead. So let's go back here. So we can understand how just making print larger is something that the patient can understand, and the goals that we want to achieve to get their fluency and get visibility. And we talked about the three options. So I had a patient a number of years ago who received a bioptic telescope. And she said to me, before I got the telescope, my world extended to the end of my arms. She had 2200 visual acuity, which is 660. And at that distance, pretty much 1 meter is the furthest distance that you can recognize someone's facial features. She said the telescope made my arms 4 times longer, which isn't surprising because it was a 4-power telescope. And then she said something I wasn't expecting to hear. And now I feel connected again. So we are taught in school that we prescribe telescopes to read signs, maybe recognize faces and recognize people, see in the classroom, things of that sort. But we didn't talk about the emotional aspect of feeling connected again. So here's a picture of a pretty young lady who's perfectly clear. If you've got 660 visual acuity, you cannot recognize her facial features. You can possibly see that she's smiling, but you probably may not be able to recognize her. And looking through a 4-power telescope, this is what you see. You can make out her smile. You can see her pretty eyes. You can connect to her. Then you notice not perfectly sharp, because we don't get perfectly sharp resolution even with that much magnification, but certainly she becomes visible and relatable too. Now, our patients ask us, what does 660 mean? What does 612 mean? And we can explain the distances that we have the eye chart and the distance of a standard individual and your vision. And they look at you and they really don't understand what you're talking about. And it's not terribly instructive either for us clinically in terms of what we're trying to accomplish and when a prescription will be valuable to the patient and when it may not be valuable. So what I'd like to share with you is a different way of thinking about vision functionally. And I want to introduce a concept of a social range and a visual radius. The social range is the distance that we kind of live at in most of our social engagements, which is roughly 1.5 meters to 6 meters. If I have to get closer than 1.5 meters to recognize somebody's face, we call that a socially aggressive behavior. I'm invading their personal space. They don't feel comfortable with my doing it, and I don't feel so comfortable doing it either. So I want to be able to see them much further away than that. And in most social settings, rooms aren't much bigger than 6 meters away. So if I can see pretty far into that 6 meter distance, then I should be socially engaged visually. Now, the visual radius is the furthest distance that one can see a face and recognize their features and make eye contact and read their body language. And of course, that depends upon visual acuity and contrast and these other variables. So let's see if we can apply that. So if the social range is 1.5 to 6 meters, and we talk about the visual radius of an individual with 660 visual acuity, which is roughly 1.2 meters, their visual radius doesn't extend into the social range at all. If we were to prescribe them a 4-power telescope and they get a full geometric gain from that magnification, and not everybody does, then now we've extended their visual radius to 4.8 meters, and that's pretty far into that social range, and we can expect this individual to get a fair amount of functional benefit from the prescription of telescope for that distance. Now let's talk about someone with 6/120 visual acuity. And that individual can't recognize a face much further than a foot or about 1/3 of a meter away. So let's see what happens to that social range. At 1/3 of a meter, she's nowhere close, or he's nowhere close, whichever, to get into that social range. So if we prescribe a 4-power telescope, and if they get a full response to the magnification, and the likelihood that at this reduced level of visual acuity, they will not get a full geometric gain to the telescope, even though we can get them to see better, it doesn't get them at all into the social range, so it may not have that functional benefit that we would like to see. So let's say we could prescribe them a 6-power telescope, and now we can extend that visual radius to 1.8, almost 2 meters, but it doesn't get them far enough into that social range to be impactful. So this is an individual who we show a telescope to in the office, and they can read much further down the eye chart than they ever did before, and they're very excited about that, and we prescribe the telescope, and they take it home. And they come back for a follow-up visit and they say, you know, it was so helpful in the exam room, but it didn't make enough difference in my real world. And this is why, because it doesn't have enough of a functional impact for them. So Cynthia Owsley from the University of Alabama in the US did a survey in 2009. They looked at over 1,200 clinics. About half of them responded. Non-VA means we have VA medical centers in the US that provide services to veterans, but the 1,200 clinics that they approached did not include Veterans Administration centers. They asked a lot of questions about all different aspects of providing low vision care. Amongst the questions they asked were, what were the client's stated rehabilitation goals? Not surprisingly, 86% wanted reading, but 65% wanted to see faces and signs. 50% wanted to drive, irrespective of whether it would be appropriate on their level of vision or not. And 41% wanted mobility, which is a distant visual activity as well. So if all we're thinking about with our low vision patients is reading, then there's a significant percentage of the activities they're seeking that are not being addressed. So for enhancing distance vision, we mortals only have 3 options. I'll tell you a cute story. Years ago, a patient came in to see me for low vision, having been referred from a center. And they said, I'm told that you walk on water, that you can do things nobody else can do. So when you have a patient that comes in that has those sorts of unreasonable expectations, you better be careful. You better be cautious and be very careful about making unrealistic promises to them. So I mentioned this to my youngest son, that this patient said, I hear that you can walk on water. And I said to him, how do you think I should respond to that? And he said, well, that's an easy one. When someone says you can walk on water, tell them only when it's frozen. So that's my little shared wisdom for this afternoon. But we mortals only have three options. We can give them a better refraction. But if a fraction made a big difference in how they saw, someone dropped the ball way before they got to us in low vision care. We'll talk more about refraction in a minute. Of course, they can move closer. Sometimes they can, sometimes they can't. You can't climb over the counter at McDonald's or at Starbucks to read the menu on the wall. You can't get so close that you invade their personal space. You can't move up to the front of the church in order to read the hymns that are being listed on the wall. And of course, we can bring it closer optically with miniature telescopes. And that's the large part of what we'll be talking about. And of course, someday there will be digital options as well. And while there are digital options that are available now, they are not quite ready for prime time, in my opinion. They're not designed for the needs of our visually impaired patients. They're not bright enough to be used out of doors. They're all being piggybacked on technology that's designed for other purposes, for gamers and for IT people and things of that sort. And we spent a lot of time at my firm exploring electronic technology for this. And we have not yet found some technology that is truly appropriate for our patients, although I'll talk a little bit more about that today as well. So in terms of refraction, I always use a trial frame. I always do a brief retinoscopy, not so long that I'm going to bleach their retina. Remember, their retina is already sick. So if we bleach it, it's going to take forever for it to recover. So we don't want to do that. But I want to make certain that we have a bright reflex. If the reflex is dull, why is it dull? Is it corneal opacity, cataract, vitreous issues? There are very few surgical opportunities in low vision care, of course. But if they have a media issue and there is a surgical option, we want to do that. We don't want to have them looking through a foggy optical system. You know, if you look through a frosted window in a bathroom, no amount of magnification is going to let you see through it. So we want to get as crisp an image on the retina as we possibly can. Secondly, we want to make sure we have a two-line gain in acuity, not two-letter, two-line, enough better so that they really notice the difference. Now, remember, these folks have gone to a bunch of doctors before they've come to us, and each one has given them a refraction, perhaps a quarter diopter or half a diopter different from the previous one, and changed the cylinder axis a few degrees one way or the other. And it hasn't made any difference. So we don't want to victimize them and ourselves by making a very slight change in their refraction, which they don't notice. And even if they see a little bit better on the eye chart, I will always ask them to look at their family member who's invariably with them at the other side of the room. And I want to see whether or not they see their family member's face better. Say, no, it doesn't hardly make any difference in how I see their face, then I'm not going to make the change in their glasses. Remember that small changes in refraction do not make big changes in visual acuity. So I'm going to spend much more time with someone who takes a small change in refraction if their acuity is on the better side to begin with, because a half the diopter difference might make a difference for someone with 620, but it certainly isn't going to make a difference for someone with 660. So don't waste your time on small changes on patients with very low visual acuity. And make enough of a change to be worthwhile. Don't bother with quarter diopters and 5-degree changes in refraction in axis. It won't make any difference at all. And let me tell you quickly how I do it. Once I know what their best visual acuity is, you know, on entrance, either with glasses or without if they don't wear them, I will put a +50 in front of each eye individually. And I ask them, what happens? Does this make it better or worse? And if they say, oh, that's a little blurry, it tells me two things right away. Number one, they're sensitive to a half a diopter change, and they don't take plus. The second thing I'll do is put a -50 in front of them and say what happens. And we all know from refracting our regular, normally seeing myopes, that if they need more minus, they know immediately. You put it in front of them and they go, oh, that's better. But sometimes they'll go, and not this title. They'll say it's a little bit bolder or darker, but they don't say, oh, that's better. Which tells you that they really are not taking the minus, because if it's going to really help them, they don't have to think about it. I had a professor once that said it goes from their eye to their mouth, it skips their brain. And sometimes that's helpful to us. But if they go, that's a non-answer. And in this case, a non-answer is an answer for us. Then I'll take a 3/4 diopter handheld minus cylinder lens. I know they don't take plus, and hold it at 90 and 180 and 45 and 135. If they don't like any of those, I'm done with the over refraction. If they say, oh, that's a little bit better, I'll spend some time with them in the trial frame fine-tuning it, but only if it looks promising. If it's going to be negligible, we're done with the refraction. It takes less time to do it than it took me to explain this to you. Of course, they can move closer. Sometimes you can, sometimes you can't. The big issue is television. No telescopic device is going to cover the whole screen. The field of view is just not wide enough. So we want them to sit close enough so they can get most of the detail that they can out of the screen. But if there's some print on the screen or a face that's a bit smaller and they can't recognize it, that's what the telescope would be for. You know, all the new TVs have lots of digital controls to increase the sharpness, increase the contrast, and you want to tell them to adjust those things to make it as visible as possible. So what I would tell my patient is to move up very close to the TV and then back off until you can't see it well any longer, and then you know the distance you need to sit. Now, if they're going to go shop for another TV, when we do that, we normally stand very close to the televisions, not at the distance that we would normally be watching it from home. So they have to determine the preferred distance that they want to be at home when they're watching the TV, and that's the distance that they stand at when they're looking at the TVs in the store. Of course, lastly, we can bring it closer optically with telescopes. And the telescope will expand the visual range by the power of the device. So we give them a 2x device, they'll see twice as far away, a 4x device, 4 times further away, assuming they're getting a full benefit from the magnification, of course. Of course, all telescopes narrow the field of view because the depth of field is very shallow, so it confines the working distances. Either we have to have a device that's focusable, either manually focusable or with a new autofocus, or reading caps. Of course, if it's a reading cap, then we're constrained by the working distance of that reading cap. So we have to figure out what that is. And the closer we get, the narrower the field of view. In addition, because of the magnified image, any head movement will exaggerate the motion that we're looking at. So if you have someone with a tremor, then a head tremor, then the image is going to move around some, and that's going to make it less helpful to them. And all telescopes reduce retinal illumination and contrast. The higher the power, the more effect that will have. So we have to think about that as well in prescribing. So why a bioptic telescope? Well, it makes it much more convenient to use. In the same way that Benjamin Franklin invented the bifocal so he didn't have to switch between his distance reading glasses, a telescope built into the glasses makes it more convenient and accessible. So in the same way that we look down to look close with a bifocal, here the patient looks up to see further away through the telescope. It's more natural because we're just easily switching the head. We're not stopping what we're doing and picking something up and aiming it and focusing it, which also makes it less aggressive than what the lady in the bottom left is doing. And it also makes it less conspicuous because I'm not bringing my hand up to my face all the time, which attracts attention from other people. And by building it into the glasses and our ability to switch from the carrier lens vision to the telescope vision, we can get what I call a fused perception. And let me share with you what I mean by that. Here's a simulation of a blurred image from somebody in a park looking at her daughter walking down the street, and we can't recognize who she is. And if we pick up the telescope and we look at her face, we can see her much more clearly, but we lose the ground. All we see is the figure. And when patients first look through a telescope, that's exactly what they'll say, oh, the field of view is so narrow. And that's true. But as they get practice learning to use it and they switch between the carrier lens and the telescope view, this is the fused perception that they can get, where they can integrate the telescopic view with the natural perception. Now, it's not simultaneous, but we can get a fused perception over time by using this. And I can give you an analogy for driving a car. So we're driving a car, we're looking in the rear view mirror and the side view mirrors, and we see what all the other traffic is around us, but we're looking straight ahead, but we still have a perception of what the cars are like around us, even though we're not looking at them at the same time. So that's what the fused perception concept is, and this takes a little bit of a learning and practice to achieve, but that's the goal of a fused perception, which you can get much more readily when the telescope is built into the glasses and when you have to stop what you're doing, pick up the device, aim it, and focus it. So the keys to successful prescribing are these. We have to address the patient's goals. They have to be appropriate for the device that we're prescribing, irrespective if it's a telescope or a magnifier or what have you. And we have to determine the patient's response to magnification. We have to order it right, we have to fit it right, and we have to manage the patient right. We have to hold their hand through the process of getting successful with it. And of course, to establish the patient's goals, we now have to think about both the functional goals of the telescope, and in this case, seeing faces and signs in the classroom and all those things that are listed there. But we also have to think about the emotional goals of a visual impairment. How does it feel to you that you don't see clearly? He says, well, I don't go to church anymore because I can't recognize people and I don't want to miscall their name. People would come up to me and say, don't you like me anymore? You never say hello. And so I don't want to put myself in a social situation where it makes me feel uncomfortable. So I don't go to those sorts of activities any longer. So if we can get them to feel comfortable in that environment, it avoids isolation and it helps support independence to as high a level as they possibly can achieve. Functional goals and emotional goals. Of course, we have two different categories of telescopes: Galilean, which is small and compact and are very helpful in the lower powers, but as they get higher in power, the fields of view get rather narrow. We have Keplerian telescopes, which give a much wider field of view, much more complicated optical designs. As you know, they're bigger, they're heavier, and they're not quite as bright and contrasty as are the Galileans, but because of all the optics that are involved in the device. So let's talk very briefly about the optics of telescopes. The larger the objective lens, the brighter the image will be, but the shallower the depth of field, the amount of focus before and in front of and behind where you focus the device. We all know that in photography, if we open the aperture, we get more light into the camera and it blurs the background, which is what, portrait photographers like to do. The field of view is not a function of the larger objective lens. The field of view is the design of the optics of the eyepiece, which specifically having to do with the eyepiece in Keplerian telescopes, where it has both an eye lens and a field lens, which gets the peripheral rays imaging through the eye lens. And of course, the closer the eyepiece is to the eye, the wider the field of view will be. We call that the vertex distance. So we always want that eyepiece lens going through the carrier lens to get the widest field of view we can. That's relevant, be it Galilean or Keplerian telescopes. So here's an example of an 8-degree field of view in a Galilean telescope, and this is what you get with a 14-degree field Keplerian of the same power. So you see much more at one time. So there was a study done in 1997, a long time ago, I know, from the VA system in the US. And they looked at 200 veterans that were prescribed 740 devices, our American tax dollars at work. And 130 of them were spectacle telescopes. Now, they didn't specify the power, the design, monocular, binocular. All they said were 130 spectacle telescopes. But the issues that the users had with the telescopes were these. 83% wanted a wider field of view, which means we need to be thinking Keplerian whenever that opportunity is available. 79% wanted autofocusing, which made us at my company Ocutech very happy because we made the only autofocus. But whether they needed autofocus or not, focusing was an issue. Having a fixed focus device was not adequate for 79% of these patients. 78% wanted more power. Now, we don't know what power they were provided, nor what the visual acuity was that they were getting through the telescope. But 78% didn't think it was enough. Also, they have to make up their mind because you can't have more power and a wider field of view. So that has to factor into this. 49% wanted a brighter image, which talks about a larger front lens. The less conspicuous the telescope, the smaller the optics will be, the dimmer the image will be. So we have to deal with that as well. Only 16% cared what it looked like. Maybe the veterans don't care so much, but I think the rest of us do. So I think that appearance certainly is a factor in these. But I think the top four are instructive in terms of what we should be thinking about in prescribing bioptic telescopes. So how do we prescribe bioptic telescopes? Not all patients are bioptic candidates. Not all patients are candidates for any health procedure, cardiac surgery, orthopedic surgery, whatever it happens to be. So there's the clinical testing that's involved to determine their response to whatever treatments are available. We establish a prognosis and we give them their options and the likelihood of success. And for seniors with bioptic telescopes who've known normal vision most of their life and now all of a sudden develop some sort of central vision disorder, it's likely that only 20% will be bioptic candidates, either because of what their needs are, their dexterity, their visual response to bioptics, and that's just their comfort with technology. Now, students who are born visually impaired, albinism, nystagmus, photoreceptor disorders, macular hypodevelopment, and the young adults who develop Stargardt's or injuries at a younger age respond very well to telescopic devices, much more robustly than seniors. Their needs are more appropriate for what telescopes can do. Their comfort with technology is more comfortable with technology. So that could be close to a 50% yield. And so how do we know? We measure their response to telescopes. And in part of a clinical trial we did that was funded by the U.S. National Eye Institute when we were developing the autofocus telescope, we did a clinical trial at independent studies and tried to determine if we can determine in advance who would be successful with the prescription of a bioptic telescope. At that point, we were talking about the autofocus device, but this was irrespective of the kind of device that we're talking about. And we were able to break it down into two parts: hard signs, which are clinical things we can measure objectively in the clinic, and soft signs, which are subjective findings. And what we determined was that if we could get them 612 visual acuity through the telescope, they could see everything they needed to see. You don't need 6.6 in order to read a newspaper or to recognize a face at a reasonable distance. And in all 50 states in the US, people with 612 visual acuity can drive with no restrictions on their driver's license. We also know that children can see everything they need to see in the classroom with 612 acuity. Let me give you the concept of 612-ish. 615 is often 612-ish enough, especially for seniors who don't have as demanding needs. Now, what if we give them a higher power telescope to get them 6.9 or maybe even 6.6? That's at the expense of a narrower field of view, which is what everybody's complaining about. Now, if you have a very high functioning individual, maybe an engineer who's very critical, you might need a higher visual acuity through the device, but you have to let them know that's the expense of a narrower field of view and let them make that decision. I will tell you that 620 is not 612-ish enough. If we're going to be prescribing monocularly, especially, we're hoping we can prescribe to the dominant eye. We all have a dominant eye, and it's much easier to find what you're looking for and localize through a monocular telescope through the dominant eye. And I would encourage you all to pick up a monocular telescope, bring it to your dominant eye, which you will probably do reflexively, and see how easy it is to find what you're looking for. And then try the other eye. And usually you will find it's much more challenging and fatiguing to find things with a non-dominant eye. Now, some people don't have a firmly established dominance and they can see with either eye adequately. And some people can just have no dominance and can switch to either eye equally well, in which case you just send up a prayer of thanks because dealing with this patient will be easier. But the vast majority of people, you want to prescribe to the dominant eye. And it's very important to think about this. I would prefer to prescribe to the dominant eye, even if it is the poorer seeing eye, so long as through the telescope I can get that 612, 615 visual acuity. I will prescribe to the non-dominant eye if I have to, but likely it's going to be a more challenging case for the patient to get used to it. And the last hard sign is the patient's response to low contrast targets. The world is not a high contrast place. The eye chart is, reading material is, but faces and the world are not. So the response to the high contrast eye chart is not necessarily prognostic of how they're going to see in the real world. So as I said before, they invariably have a family member in the exam room along with them. And after I'm done with the eye chart, I ask them to look at their family member face through the telescope at the other side of the room in normal room illumination. And I want them to pass what I call the O test. And you may not have gotten the O test when you were in school. The O test is spelled O-H. And the O test is when the patient goes, oh, I can see them so much better. So I want them to pass the O test. That tells me that they're getting enough contrast through the telescope to be able to see a low contrast target well. Now, some patients will say to you, I see the face larger, but I don't see it better. And what they're telling you is that the reduction in contrast through the telescope is undermining their ability to see clearly. And so I'm going to be very careful about prescribing this. If they're going to be using it out of doors, then probably it will be bright enough. But if they're not expecting to use it out of doors, they only want to be inside, then this may not be a successful prescription for them. Now, I will do a test with a patient with a telescope, even if I have no intention of prescribing it, because I want to know what their dominance is, I want to know what their dexterity is, I want to know what their response to low contrast targets are. But in addition, it's recruiting them into the process of a low vision exam, because we're likely with the telescope to have them see further down the chart than any of their previous eye doctors have been able to accomplish. And so that gets them excited. The family members see that, oh, this doctor can do something that the other doctors couldn't do. And that is effective at recruiting them into the process of what we're going to do. So I always put a telescope in front of them for this purpose, even if I have no intention of prescribing it. And it takes very little time, as I said. The soft signs, the subjective signs, are also three. Appropriate goals for use of the device, which are mid-range and beyond, arm's length, computer screens, tabletop activities, music, things of that sort, and beyond. You can read with telescopes, but it shouldn't be the primary goal of use of the device. If the sole goal is reading, we have much better compelling options for prescribing than telescopes. Secondly, what's their dexterity? And not just their ability to focus the device and find what they're looking for when looking through it, but also their cognitive dexterity. Do they understand what this is all about, how they would apply it, and understand what the purpose of this is? And lastly, what's their motivation? Are they willing to wear something in public that makes them look a little unusual? Are they willing to take the time and spend the money and to be successful with it? And Mrs. Smith may say, it's going to look like a regular pair of glasses when it's done, right? It won't look like this. And we'll say, no, it's going to look just like this. And they say, well, hell no, I'm not going to wear something that looks like this. And that's their privilege. And other people will say, you know, I don't care what it looks like within reason. If it's going to help me do these things the way I want to, then I'm willing to wear it. And if you can say yes to all these 6 things, you've got a very highly successful patient. And I will give them a prognosis on a scale of 1 to 10 based on this. 10 is perfect, 1 is poor. I never offer a 10. I think that's promising too much. I never give a 1 or a 2. I think that's too depressing. If the patient's doing very well, I'll give them an 8 or a 9. If I'm a little bit worried, but I think they'll do okay with practice, then I'll give them a 7. If I really don't want them to pursue it, I'm going to give them a 4 or a 5. And I tell them that the purpose of this visit is a fact-finding mission to see what options are appropriate for them, for their goals and their response to what we can do. And we'll write down this on the record that this is what we prescribe, but go home and think about it. Don't feel any obligation to make a decision today. And in my practice, about 20 to 25% will call back and say they want to do it. I would rather not prescribe a device than have to take it back. We can reuse Ocutech telescopes and most other low vision aids on different patients, but it colors the experience. The patient feels that they've been unsuccessful, they're a little less trusting. It just makes it more challenging in terms of supporting them in their prognosis. So I would rather underprescribe and underpromise And the clinical trials showed a 78% acceptance rate in the trial. But I will tell you that if you can hang your hat on these 6 items, you'll be even more successful than that. So how do I do it in my practice? After we talk about acuity, I know which eye is the better seeing eye. I know what their acuities are. If they've got 630 acuity or better, I will hand them a 2.2 fixed focus Galilean. I couldn't find a picture of just one, so there's a picture of 2, but you only need 1. And if the acuity is 640 or worse, I will take a 4x12 handheld Keplerian, which I pre-focus for the chart distance. I hand it to them, and I say, pick this up and look through it. And I've got my fingers crossed that they're going to take it to their better seeing eye, because that's going to be their dominant eye. If they say, well, which eye should I use? I say, whichever eye feels more natural, and I don't want to leave the witness in, and we find out how they're doing. And then, of course, I want to see what their response to the low contrast target is. I want them to pass the O test. In terms of what power, you can do the math just as well as I can do the math, the goal being 612 or 615 to the device. I will point out to you, as I mentioned earlier, that when acuities are worse than 660, you may no longer get a full geometric gain. So you may wind up needing a little bit more magnification than you expected, both because the retina is a little bit more challenged. It may not be a dry retina anymore. The margins of the scotoma may not be as succinct, and the telescope is reducing amount of retinal illumination so that you need to get a little bit more magnification to get the full gain. When powers are higher than 6x, it's very hard to keep it stable on the head. So you really don't want to be thinking about prescribing devices higher than 6x in a bioptic design. When you need more than that, and especially for sporting events and outdoors, then it's time for traditional sports binoculars. Which eye do we want to prescribe to? Well, if we can prescribe binocularly, that's always desirable. It's much more natural. Patient gets a cyclopean eye experience. You get a little bit wider field of view. We get summation of acuity and contrast, and it lessens the impact of scotomas and suppressions. But the reality is we have no compelling wide field telescopes above 3x, and the 3x is the decision point. And in my practice at 3x, I still pretty much only go monocular. And of course, if we have to go monocularly, we would prefer to prescribe to the dominant eye if at all possible. So as I said before, the decision point is 3x, and the goal is to get a 10-degree field of view. It's much harder to find when you're looking for when fields of view are narrower than 10 degrees. So that's where the decision point is at 3x. I usually prescribe Keplerians at 3x. There are some Galilean options at 3x. Beneath 3x, there are no 1.7 and 2.2. We only have Galilean options. You know, there's a 2.75 and a 2.8 Keplerian. In my book, that's the same thing as a 3x. So in my practice, I've always used Keplerian at 3x and higher. And you can see how narrow the fields get in Galileans above 3x. But you can't tell a book by its cover. Here are 3 3x telescopes. Number 1 is Galilean. 2 and 3 are both Keplerian. The fields of view of the Keplerians are much wider. Look at the difference in size between number 2 and number 3. The fields of view are virtually the same, although the image of number 3 is much brighter, not much brighter, moderately brighter, but at the expense of a much larger, heavier, bulkier device. And of course, it's not just enough to hand them the device. They have to learn how to use it, and we do that incrementally. They have to be comfortable putting it on and taking it off and putting it in the case and not smushing it around and putting it out of position when they handle it. I've seen doctors not let the patient handle it at all in the office, and the first time the patient handles it is at home. So that's not a good idea. And remember, if they can't do it well in the office with you looking over their shoulder or your support staff looking over their shoulder, they won't be able to do it at home on their own. So make certain they're comfortable doing it in your office before that you send them off. But the reality is, if you've got a successful patient, it's going to be very smooth sailing. And if you don't have a successful patient in the office doing all this demonstrating, there's very little we mortals can do to change that. And then you just move on with other things and say, I'm not optimistic you're going to thrive with this. So let's talk about other options and the other goals that you have. And of course, the real world is not the exam room. And we take them out into the testing, in a different testing room, and we have samples of supermarket products on a shelf, and they can go look at those. We give them experiences close to what they might experience in their real life in there, so they can see how this can impact their functioning. And they may start to ask you questions like, will I be able to do this with that? May I be able to do that with that? And you don't want to answer all of these questions. You'd much prefer to give them a way to answer them themselves. So the way to do that is to say, well, what you can normally say at 2 meters with a 4-power telescope, you can now see at 8 meters. You won't see at 10 meters. So you may have to move up a little bit closer to see it, but not nearly as close as you would have before. Let's talk about driving for a minute. In 47 states in the US, individuals with a certain level of visual impairment can get a bioptic telescope and make them legal to drive. So, and that is quite a great motivator for driving. That's being done in Australia. I don't know where it is in South Africa, but certainly there are individuals that can benefit from that and can be very safe drivers with a moderate amount of visual impairment. So of the top 25 causes of motor vehicle accidents, visual impairment does not exist. That doesn't mean you might not have had trouble seeing clearly because of weather or fog or what have you, but it's not a function of their own vision problem. It's a function of environmental factors. Gary Rubin at Moorfields Eye Hospital in London did a study in 2007 looking at 800 seniors, and they did every vision test they could think of. 120 of the subjects had accidents. Predictors of crash involvement were glare, not surprising, a visual field loss, not surprising, and useful field of view, which is a functional test to test the ability of the individual to be aware of activities or targets in their periphery when the patient is put under stress. You know, we all have a physiological visual field, roughly 180 degrees, but if we put under a lot of pressure, our physiological visual field can constrict so that our perceptual visual field gets narrower and we stop seeing things in our periphery, which puts us at greater risk. What was not predictive was visual acuity, contrast, and depth perception. So when we start thinking about what's involved with safe driving, or for someone who is visually impaired, clearly we want them to see signs and traffic signals. What we do know is that visually impaired usually only go where they know where they're going. So seeing signs becomes less important. Certainly signals is important. But what we are really worried about being on the road with someone who's visually impaired is we don't want them to crash into us. And so what motor vehicle inspectors are concerned about regarding having someone be a safe driver is that they can maintain their lane position. We all get nervous if we see someone weaving in and out of their lane, that they can merge and change lanes and pass and exit appropriately, that they can see far enough up the road so that they can avoid obstacles. And what makes us all a safe driver is the ability to anticipate a possible problem and respond to it in enough time to avoid getting into an accident. Youngsters don't yet have that road sense, and seniors may lose that road sense. And so these are the things that make people safe on the road. And this has very little to do with visual acuity. And so we really don't know what the minimum visual acuity is. There are lots of questions about whether you need a wide or a narrow field of view, whether a binocular or monocular telescope is appropriate, whether it should focus or not focus. And in the regulations in the US and all the states are all over the place. Everyone has well-intentioned regulations, but nobody really knows. And then there's also the question of the ring scotoma. And there's also confusion about what that ring scotoma is. So let me explain it to you. So here's a simulation. We see the little fella on the bicycle in the center screen here, and he's magnified 3 times with a 3-power telescopic device. Now, the magnified image won't be off to the side. It will be superimposed on him, of course. And the black ring is the chassis. So the larger image, along with the chassis, obscures the image around the normal size individual. So everything in the red hashed area is not seen, which means you don't see the person on the bicycle in front of him, and you may not see the lady who's walking into the crosswalk. So that's the ring scotoma that could cause you not to see something that might be important. However, we only look through a telescope for very small periods of time, 1 to 2% of the time, much less time than it probably takes to change the radio or adjust the air conditioner, where we're looking in the side view and rear view mirrors, where we're not looking forward at all. So if 1 to 2% of the time is the only time we're looking through the telescope, 98% of the time we're looking through the carrier lenses. So we have to be a competent driver without the telescope. A bioptic telescope will not make an incompetent driver competent, but can make a competent driver a safer driver. And let me give you a for instance. So here's a four-way stop. And if two cars get there at exactly the same time, the rule, of course, is that we look to the right, to let the person to the right go first. But do we trust that? Not really. We look in the car of the person in the other car, who I like to call the enemy, and we see where they're looking. And this person isn't looking at us at all. We don't know what they're going to do. So we're going to certainly let them go through the intersection first. Now, what happens if we get there and the person in the other car has a tinted window and we can't see in? How do we feel about entering that intersection? The answer is very uncomfortable. So if we have 2100 or 660 visual acuity, we can't really see that individual very clearly either. But with a bioptic telescope, we can. So it's these on occasion variable extenuating circumstances, situations where a bioptic will be helpful, but that's the situations that can get everybody in trouble. And this allows them to do something they might not otherwise be able to do. There are plenty of studies that demonstrate the value and benefit and safety of using bioptic telescopes. So I'm not going to spend much time on that. Let's talk about digital. When the Google Glass came out, everyone in low vision was excited because it could become acceptable to start wearing gadgets mounted on glasses. And by and large, people would not recognize or differentiate between a Google Glass and a bioptic telescope. And of course, it did not go over so well. And part of the reason was that people would be looking into the Google Glass to read their phone, to read their email, to do whatever they were doing. And it was disassociating them from social interaction with the people they were around. It was interfering and disengaging them. And that was very off-putting. Of course, when we're prescribing devices, it's support visual engagement and make eye contact. So it would not be as disengaging as the Google Glass became. Of course, for the digital devices that are on the market now, and I fully recognize there are slightly newer versions than these, we're piggybacking by and large on digital technology that was not developed for visual impairment, even though there's software in these things that were for low vision applications. They all close the patient in because the displays are not terribly bright. So if you go outside in the sun, you can't see the displays in the same way you can't see your phone, you can't see the back of a camera in bright light. They're heavy, they get warm, their battery life is only several hours. And so in the same way that they want to make eye contact with us by looking into the device, we want to make eye contact with them, and having this close them in completely disengages us from the social interaction. In addition, we have to piggyback on technology that was designed for other purposes, and it changes fast. So for developers of these devices, by the time they've got it figured out, that technology isn't there anymore. And the other concern is that to make the device display bright enough so that it can be seen out of doors by low vision patients, it's so bright that there's risk that it can actually damage the retina by how bright it is. So there are a number of different devices. Orcam, of course, is an optical character reader. It's gotten a lot of publicity and it's very effective, but it's not a vision device at all. It won't let you see anything. It will read to you. You can train it to recognize people's faces, but doesn't let you see them. It only tells you who they are. So in terms of recruiting patients for our services, we have to be thinking about how they're thinking about things from their side. We don't want to push anything. We have to assume that they're there because they want to improve their vision. The adult kids want to bring their parent in and help them with everything you can do for them. And they say, money isn't an object, but we'll get them whatever mom needs. and they may force you to prescribe things against your better judgment. So if this happens, tell them that this is a fact-finding mission. You're making suggestions. Don't make any decisions now. Go home and think about it. And grandma will get in the car with them on the way home and say, will you leave me alone? I know you want to be helpful, but I'm not into this. I don't want to do this, or let's do this and not that. And don't be a victim of the well-meaning kids forcing you to do things against your own judgment, because you will get blamed if it doesn't work well, even though it wasn't your fault. So do explore the benefit, offer a prognosis, explain the sales and refund policy. Remember, they've probably gone to other doctors before us and have spent money, and they're thinking to themselves, how much money am I going to waste this time? And so they are thinking about money when you're explaining the benefit and their prognosis, and you have to address that so they can get their head around it. Clearly, if you say they'll get every dime back, then of course they'll say yes, because they're not taking any risk. You want them to be spending some money. You want them to have some skin in the game, so they're motivated to make an effort to be successful. But you have to address this issue, and you have to decide how you're going to deal with these issues. And as I said before, let them go home and think about it. Take all the measurements first. So if they call you up and say, yeah, I want to do it, you've got this. And I have found that if you say, look, you don't have to make a decision today, you go home and think about it, oftentimes that takes all the pressure off them, and they wind up making a decision right then and there after all. So it's the patient's job to want to improve their vision. If they're not motivated to make the effort, then why do we want to try? We're not there to convince them. They have to be prepared to be frustrated and to invest the time and the money. And I had another professor who said, we can teach them to ride the bicycle, but they have to do the pedaling. If they're not prepared to do the pedaling, then what's the point of teaching them to ride? So likely promising diagnoses for visual disorders include these. They all are dry. They all have defined scotomas. They respond well to telescopes. These folks have wet macular degeneration or a wet retina. They have reduced contrast, either from optic nerve disorders or from glaucoma or ischemic optic neuropathy, of course, or media issues. And they're less likely to respond to telescopic magnification. And these folks might do better with the head-mounted digital displays because we can increase the contrast, especially in acuities of 660 and worse. Now, in terms of prognosis, patients 660 and better do very well. And so I would tell my ophthalmology referral sources, their goal is and job is to keep the patient 660 and better. Your prognosis will drop off 660 to 690, and 690 and worse, it's much more challenging to help these folks. And of course, people with RP and choroideremia have narrow fields of view. And what a telescope does, and even what the head-mounted display, digital displays do, is enlarge the image and put it on peripheral retina. And if you don't have functioning peripheral retina that works, then it won't be helpful. And in fact, it can be counterproductive. Now, I don't expect you to remember anything we just chatted about for the last hour. You can download a worksheet from the Ocutech website, and we even have a video webinar that takes you step by step through this form that will help you process this. And if you do it once or twice, you don't even need the form anymore. It's pretty straightforward. So let's apply this to a couple of patients. Just to reiterate, the prescribing goals are acuity 612, give or take. We want to use the dominant eye if at all possible, and we want to prescribe a device that's at least a 10-degree field of view, which means in my practice, 3x and higher, I go Keplerian. So patient number one, 83-year-old female with macular degeneration, 2400 in the right. I'm sorry, I didn't put metric acuities in this, 2200 in the left. Right eye is the dominant eye. The right is the poor seeing eye. Faces through the 4-power telescope with the dominant right eye, 2200. She didn't even get a full 4x gain, which would have been 2100. And the left eye, which is a non-dominant eye, she couldn't even find a way to look through the telescope. So this isn't looking good, is it? Her goal, she wants to read. She wants to watch TV. She has rheumatoid arthritis. She's got a mild hand tremor. She's of small stature. Her children are eager to help her and will buy anything that grandma wants to help her see better. Clearly, she's not a telescope candidate. I would give her a digital magnifier on a reading stand, inclined reading stand, because we need something that she doesn't have to hold because of her hand tremor. I would sit her as close to the TV as we possibly can and tell the kids to go buy her a bigger one. She is not a telescope candidate, obviously. Patient number 2, 18-year-old with oculocutaneous albinism. He has nystagmus. They all do. It may be a large angle, it may be a small angle. They usually have a strabismus, but not always. He has a left esotropia, so if he's got a left ESO, then obviously his right eye is dominant. He's got hyperopic astigmatism. He only wears his glasses occasionally. He finds them not very helpful. And you will find that while all folks with albinism and nystagmus have a lot of astigmatism, they may be hyperopic, they may be myopic. And the hyperopic ones rarely find their glasses helpful. Myopic ones usually do. We're taught in school they should have sunglasses, but they don't often like sunglasses. They would much prefer to wear a baseball cap. And these folks read without trouble. They're so used to holding things close that they read like champs, much better than their distant visual acuity would suggest. And only when they get older and they get presbyopic do they really think you're going to want to give them an ad. He does, with a 4X, he gets his 612, 20/40 minus. He's got a small angle nystagmus. He's very happy. He sees his family members from across the room with through the telescope perfectly well. He passes the O test. And of course, he wants to drive, and he's an excellent candidate for that. When a kid with albinism or nystagmus or rod cone or achromatopsia comes in, I'm a happy guy. These folks are very, very easy to help and support in school, classroom, driving. And if you wait until they're in their 20s to help them, they will say, gee, this could have been so helpful to me when I was younger in school. It would have helped me in travel, would have helped me in my job, would have helped me at school, helped me at work. It helped me in social settings. So think about kids, and I get very aggressive with parents to get kids telescopes and binoculars and bioptics at a young age because it can be so impactful for them. Number 3, 39-year-old with Stargardt's. This was an African-American patient, and you would think normally that macular degeneration is a Caucasian disorder, and by and large it is, but we have Black patients with macular degeneration and Stargardt's disease as well. She's got 2200 in the right eye, 2300 in the left. She wants to drive. She wants to see her teenage kids in school and soccer and theater and stuff like that. She works at an IT company and she has to go see PowerPoints on screens. Her left is dominant. It's a poor seeing eye. She sees 20/50 in the right eye with a 4X, only 20/70 in the left eye. We need 20/40 to get her an unrestricted bioptic driver license in North Carolina, where I am. She does perfectly well seeing faces through the telescope. Dexterity is no problem, and she's super excited. So what am I going to prescribe for her? Because I would rather prescribe to her dominant eye, which is the left eye, which is only getting 4X through a 20/70 telescope. So remember, I said I would much prefer to prescribe a higher power telescope to the dominant eye. So we wound up giving her a 5X telescope for the left eye, gave her her 20/40, and she was able to get her driver's license that way. Now, in some states, you can't go higher than 3X. In some states, you can't go higher than 4X. So that would titrate what our options were and the level of licensure she could get. But in our state, there's no limit on the amount of power for driving. So that's how we dealt with her. Patient number 4, 65-year-old with diabetes. He's had it for a long time. He's had some laser. He's got mild NS. Doc, I just want to see better. And we are all taught in school that low vision is task specific. We want to try and define what it is they want to see. Do they want to see signs or TV? So you start to ask them, what is it you want to do? You want to watch TV? Nah. There's nothing on TV worth watching. Do you want to read? I've never been a reader. Do you want to see your friends and family? Nah, I don't like them at all. I don't have to visit them anymore. You want to go to church? I've never been a churchgoer, even before I've had trouble with my vision. Doc, I just want to see better. And what that tells me is he's missing his distance vision. He's just not connected with the world around him. That's how I interpret that. So best corrected VA, 2100 in the right eye. So that's 630, left eye 660. Retinoscopy is dull because he's got NS in both eyes. He took a negligible prescription. He wore over-the-counter reading glasses. Right eye is dominant. We tried him with a 2.2x, not clear enough. We tried a 4x, too dull. 3x, no better. Doc, can't you just get me some better glasses? Folks, we can't help everybody. And here's a fella that we can't help. So this is a guy that needs counseling. We can talk about non-optical support, really bright light, contrast filters out of doors, maybe some social work, but we just can't help everybody. We need to know how to do that. We need to give them the next step. So then you don't walk out and doing what an ophthalmologist tends to do with their patients, which is say, sorry, can't help you. There's nothing that can be done, and walk out the door. We don't want to say that to these folks. We want to say, I'm going to send you to a social worker. I'm going to send you to an occupational therapist who's going to get you activities of daily living. So we give him something he can do. He may not pursue it, but we want to give them an option. We just don't want to leave them stranded. Last patient. 23-year-old with a large angle nystagmus. She wants to drive. They all do when they're young. 21, 25 in each eye. She's got an alternating left exotropia. Right eye is dominant. Acuity with the 4-power telescope, 20/30. That's great. We're good with that. Faces are good, but Doc, she says, the image turns on and off. I'm looking through the telescope, and 1 minute's there, the next minute it's off. Now remember, a Keplerian telescope has an external exit pupil. So when you image the telescope on her eye, you can put a pen light in front of it, and you're going to see the exit pupil on the cornea. And you'll see, we want it to be going into the pupil all the time, but if she's got a high angle nystagmus, the pupil is going in and out of the exit pupil, which is why it's turning on and off. Now with the 2.2 Galilean, which has an internal exit pupil, and it has a very large front objective lens, the image was much more stable. So we were able to get her 20/70 through that, which made her eligible for a less lenient bioptic driver's license, but a less lenient bioptic driver's license is better than no driver's license at all. So don't let perfect sometimes be the enemy of good. So that's the lesson from that. As you know, I am also involved in designing bioptic telescopes. And our goals in designing them, as being both a clinician and a designer, is to make them easy to use, get rid of the worry that the prescriber has in prescribing these devices. We want to maximize the field of view with Keplerian devices or the widest Galilean we can create. There's a cute saying in design, which is if you can't hide it, you have to celebrate it. And so we made the cases as high-tech appearing as we can. So compare the top one to the bottom one, which is the Ocutech Explorer. We now make them in colors, so that makes them more fun to wear. And we make them as easy and natural to use. The easier it is to use and the more comfortable it is to use, the more likely the patient will use it. Our most popular device is the Sport 2, is a Keplerian monocular, comes in 3 different powers, appropriate for individuals with 2300, 690 and better. It has a focusing knob in the front, which will cover eyepiece corrections from +12 to -12 and up to a 3-cylinder. So when you demonstrate this to the patient, if you can get the acuity you want through it, it tells you you do not need an eyepiece correction. The Explorer is a slightly smaller version. It's not quite as bright. Comes in 3x and 4x, also focuses very close, also the same range of carrier prescriptions that can be just focused in, appropriate for 2200, 660 and better. Now you might say, well, if they're both available in 4x, why would I choose the 4x Explorer as compared to the 4x Sport? And the 4x Sport is going to be brighter because the entrance window, I'm going to go back and is much larger in the Sport than it is in the Explorer. But for kids with albinism and nystagmus or photoreceptor disorders where they don't need as bright an image to begin with, and they tend to be smaller, and this is a smaller device, it cosmetically looks more attractive. The mechanical design is which gets rid of all the worry in prescribing these. So we have a mechanical mounting. There are 2 screws on the back. You loosen the screws, and you can slide the telescope right and left to line the eyepiece up with the eye. You loosen the screws a little bit more, and you can slide it off the mounting rod, flip it over, and then you can put it into position for the opposite eye. In step 2, we adjust the nose pad so that the bottom of the eyepiece aligns with the top of the pupil. Now, the eyepiece is 12 millimeters in diameter. The cornea is 11.5. So if you line the eyepiece up right above the cornea, you're 9 out of 10 times in exactly the right place. Step 3, when the patient drops their head to look through the telescope, we want to change the viewing angle of the telescope to match the viewer's line of sight. So we're just going to tilt the angle up and down until it's parallel, and the patient says, oh, now I've got a nice, bright, round image. If the tilt isn't right, then you're going to get vignetting, which means you'll lose some of the field of view, and the image won't be as bright. And when you get it right, you'll tighten the screws. And again, it takes longer for me to explain it than it does to actually do it. Now, the eyepiece protrudes through the carrier lens. We talked about that, and that's to give the patient the widest field of view we can. Now, when you're demonstrating it to the patient in the clinic, there won't be carrier lenses in it, so you can move the eyepiece wherever you want. But when we're going to put it into their order, there's going to be a slot in it, and the slot is going to allow you to get the eyepiece to go through the carrier lens. So we need to know what the PD is. And so the best way to do that is once you've demonstrated to the patient and you know where you want the eyepiece to go, you measure from the center of the bridge to the center of the eyepiece, and that's the PD that you order, and you will never go wrong that way. When they slot the lens, there's a millimeter of wiggle room around it, so you can fine-tune it if you need to. But this is a much more successful way of determining the PD than using a pupillometer or a PD gauge, because if they have any eccentric viewing or nystagmus or a slight head turn, then all bets are off in terms of what you do. But here, they've had the telescope on their head. They're telling you the eyepiece is in the right place, so you can't go wrong that way. The Sightscope is our Galilean telescope design. It's available in 1.7 and 2.2, and a 0.5x field expander for tunnel vision. It's just like a pair of binoculars where you can slide them right and left to line them each for each eye. And because we can slide them, we don't have to have the images of each telescope perfectly overlap. They can be overlapped with an extension, so we get a wider field of view. In the same way, when you separate the sides of a binocular, you get a wider field of view. And these provide the widest fields of view binocularly that you can get in any Galilean telescope. Completely adjustable for the PD and the line of sight. You can prescribe it monocularly or binocularly. We have reading caps for +1 to +4 and half diopter steps. And they all have base and prism, so you can fuse at near. These are appropriate for individuals 630 and better. We have both frame-mounted and clip-on options. All this information is on the website, and we make the world's only autofocusing telescope called the Falcon. It's a true bioptic design. Wherever you look, the image is clear immediately. It provides the most natural magnified vision that you can get. When you look through a telescope that's misfocused, you can't see anything. So how can you find what you want to aim it at and focus it on if it's not at all clear? So here you don't have to do anything other than look. Otherwise, it would be perfectly clear. And it doesn't close the user in like the digital displays do. So in the same way, as I said before, that they want to make eye contact with us, we want to make eye contact with them. And this allows us to be able to do that. And as a result, it supports social interaction. You could use it for mobility. You can use it at mid-range, you can use it at near. And of course, prescribing for mid-range is probably the biggest challenge in low vision, because that's the distance where the depths of fields of telescopes are so shallow. And with an autofocusing telescope, it's in effect, you have an infinite depth of field because you can move in and out and it stays clear all the time. These are Keplerian telescopes available in 3x, 4x, and 5.5 powers. The eyepiece covers from +8 to -8. If you have a patient who you're demonstrating it to and they have a prescription beyond that, you might have to put a temporary contact lens on them for the purposes, but you can order an eyepiece correction in any power that you need. Now, oftentimes we have doctors that say, well, I think this is something I should be prescribing. What do I really need? Do I really need one of everything? And the answer is no. We have a starter kit that includes the 4X Sport 2, the 3X Explorer, and the 2.2 side scope. And these three products, and a pair of +2 reading caps, these three products will likely cover 80% of your prescriptions. And you can extrapolate from these if you need a higher power. And they have a special on this at Ocutech at half price. It's pretty much a bargain. You can order directly from Ocutech should you need to. We have all sorts of clinical support, and you certainly have my email address, and I'm happy to talk to people about specific cases anytime. I'm doing that a lot, and I'm happy to help you. As I said before, I have been doing low vision for 40-odd years. So even if it has nothing to do with telescopes, if you've got some questions about dealing with the case, I'm happy to offer my input on that. Anyway, the take-home message is bioptics are fun. They are easy. They are rewarding. They can impact your patients' lives in ways that you can't imagine. And it's also rewarding to your practice in terms of the fact that you breed loyalty from patients, because very few people can offer these services. You're not going to lose them to competitors, and they can be remunerative. Anyhow, thank you very much for your hour and a half. There's my email address. Feel free to reach out to me should you need to. I'm going to stop the share and you can kind of see what I look like. And I hope it was worthwhile.
Thank you so much, Henry. That was absolutely great. So I just want to make sure that you can all see the link there to click on. Hayes, will you take the questions, please?
Yeah, sure. So far, Henry, we've got 2 questions. The first one is from Carolyn. She says, thank you. This is so interesting. Dealing with children with special needs and may not be able to verbalize or communicate a clear response, especially dominance. Do you have some tips for this for me to encourage my pupils' parents to still pursue an assessment with an optometrist?
What I get very aggressive about directing patients, parents of patients, because they don't yet know. They might be told by their pediatrician that there's nothing that can be done. They need to be put in special education. They're going to be blind. They're never going to drive. Teach them Braille. Get them a dog. When they really don't know what they're talking about. And even I've seen that in pediatric ophthalmology and even in general ophthalmology. So I say, you want to do everything you possibly can to help your child be as successful as they possibly can and ultimately be independent. So it never hurts to explore these options. And not only do you want them to see well, you want them to be able to socialize, because making eye contact, reading body language impacts how the child learns to socialize with their friends and classmates. So being able to see that is very important. And there's the benefit of a monocular telescope, because you can support that. And we produced, with a bunch of educators and other optometrists who do a lot of pediatric low vision, a whole brochure for parents of visually impaired children, talking about all of these sorts of issues. And if you remind me and send me an email to remind me, I will send you a link to download that PDF. And so for children, I want to give them a monocular. It's too soon to give them a bioptic telescope, but I want them something easy for them to use, something they don't have to manipulate. Remember, don't let perfect be the enemy of good. If you can give them a handheld fixed focus 2X or something like that, and it makes them see twice as far away, that's better than nothing. So we start there, and hopefully that they will get comfortable using these things. And I think what they have to just be reinforced that you want to do everything you can for the patient. In terms of figuring out what the kid's dominance is, if they've got strabismus, it's obvious. It's the eye that's straight. And if it's not obvious, let them pick it up and look through it. And just put it in front of them and say, pick this up and pick it up to your eye. And they'll do it reflexively.
Thank you. That was great. I have one more question. It says, hi, B, but this is a solution to most of us. However, do we have it in South Africa? And if so, at what amount? And if not, can Dr. Hazel, that's me, arrange something like that for us? So Ocutech is available to any optometrist. You can actually deal directly with Ocutech in America. Go onto their webpage, www.ocutech.com. Am I right, Henry?
You are very right. You're a good salesperson.
There's loads and loads and loads of information. There's beautiful videos. There is brochures that you can download. You can order directly online. You can also order via Alan Kay from Danker Lenses.
Correct, you can. And feel free to reach out to us if you need to. As I said before, spend some time on the website. I think what differentiates our website from many other vendors of low vision aids is that we have a lot of clinical support information, because we're companies run by a clinician, me. And so I'm sharing what I've learned from 40 odd years of doing this, and also being involved in product development. So there's a lot of clinical information there that I hope you'll find useful. So please spend some time with it.
Can I also add, I find it very useful to send the patients to the website, because they too can see what you're talking about, you know, if you've demonstrated and shown them. And today with the web, so many people have access to websites, and it's very useful for them as a patient, not only you as a practitioner, because there's two aspects to your web page.
Right. And to piggyback on that, thank you again. To piggyback on that, we have another brochure, which is the Consumer's Guide to Ocutech Bioptics, which was written for consumers and has a lot of information for prescribers as well to help with decision making. And if you I'll send you a link to both PDFs, which you can download. And they're all on the website. And on top of that, we also have some, the website is very consumer oriented, and our motivation on the website is to get patients to say, this is something that might be helpful to me. I'm going to go to a low vision specialist and see if this will be indeed helpful. And so that's the whole purpose of what we're about, to motivate patients to go see a low vision doctor. And so we have self-assessment questionnaires and lots of other things to help patients get motivated to pursue a low vision exam.
Okay, I don't think there's any more questions, B, and it is 7 o'clock, so I think most people are finding it's time to say goodbye.
Okay, so
Henry, from my side, thank you very much indeed for the most informative webinar. We've all learned so much, and as always, it's very, very practical information and hands-on that as a practitioner you can take back home to your practice and get going straight away. So let me just add one little bit of advice for anyone that is still on. If they do need any assistance from me or any of my feedback as well, I'm very happy for you to contact me, and I can help you through the process as well. Over to you, B.
Thank you very much, Henry. That was fantastic. And just thank you to Alan Kay from Danker Lenses for sponsoring tonight's talk.
Thank you, Alan.
Thank you very much. And we look forward to chatting to you again.
Bye-bye, everybody.
God bless. Thank you so much. Thank you so much, everybody. Good night.